Hello and welcome. Thank you for joining today's presentation, Health Literacy Considerations in NCCN Guidelines for Patients. My name is Tanya Fisher and I use she, her pronouns. I'm a medical writer for patient information at National Comprehensive Cancer Network, or NCCN. I have no disclosures or conflicts of interest to report. A little bit about me. I hold a master's in educational leadership from Northern Arizona University and a master's in library and information science from the University of Wisconsin-Milwaukee. I also have a BFA in painting from Arcadia University. I have experience in public and medical libraries, as well as patient education and teaching. The objectives and learning outcomes for today. This presentation will provide an overview of NCCN, NCCN guidelines, and NCCN guidelines for patients. By the end of this presentation, you will be able to identify how NCCN guidelines for patients apply health literacy, numeracy, and ADA design principles. You'll be able to reflect on challenges and considerations for writing patient education, and you will be able to identify health literate cancer-related resources. NCCN stands for National Comprehensive Cancer Network. We are located in Plymouth Meeting, Pennsylvania, just outside of Philadelphia. NCCN is a not-for-profit alliance of 32 leading cancer centers across the United States, devoted to patient care, research, and education. Its mission is to improve and facilitate quality, effective, efficient, and accessible cancer care so patients can live better lives. This mission is accomplished through the NCCN Clinical Practice Guidelines in Oncology, or NCCN guidelines. Clinical practice guidelines are treatment guidelines. NCCN guidelines are the standard of care for cancer in the United States and are used worldwide. 83 NCCN guidelines feature 218 algorithms that apply to 97% of cancer cases in the United States. Guidelines include prevention, cancer screening, survivorship, and supportive care. As mentioned, NCCN guidelines are the standard of cancer care and the basis for insurance coverage in the United States. They are the most thorough and most frequently updated clinical practice guidelines available in any area of medicine. These guidelines are free and can be accessed at nccn.org. Registration is required, but this information is used only to track downloads. Anyone can register to access these guidelines. You do not have to be a healthcare professional or anything like that. And here's a screenshot of the website to give you an idea of what types of clinical practice guidelines, or CPGs, we have available. Just give you a moment to look at that. In 2021, there were over 1.3 million downloads from over 180 countries. Each guideline is developed by panel members selected by member institutions. As mentioned, there are 32 member institutions. Panel members are not paid for their time. Each panel has 31 to 35 experts. More than 1,700 panel members participate in developing and updating the NCCN guidelines. Panel members contributed more than 40,000 hours in 2021. These guidelines are the basis for the NCCN guidelines for patients. The NCCN guidelines for patients, or patient guidelines, are funded by the NCCN Foundation. The NCCN Foundation is a non-profit organization that raises funds for the NCCN patient resources, including new and updated patient guidelines, as well as webinars and animations. These are funded using financial support from generous donors, and donors do not have input on the content of the books or other products. The NCCN guidelines for patients are based on the NCCN clinical practice guidelines. They explain the same options for cancer care, but are written for patients, their caregivers, family, and friends. So on the left, we have an example of the NCCN guidelines for patients, pediatric acute lymphoblastic leukemia, or ALL. And on the right is a sample of the cover of the clinical practice guidelines. And as mentioned, you have access to both of these free on our website. There is an app for the patient guidelines as well as the clinical practice guidelines. And you can order the patient guidelines through Amazon. There is a fee for that, however. And here's a sample of some of the more recent covers. This is a slide of the official patient guideline development process. You can see a lot of work goes into each book. We're continually updating our books. This process starts with attending panel meetings and learning the disease, how it is diagnosed and treated. Writers apply health literacy and numeracy principles, and books go through a rigorous medical review process. They also go through layout, copy editing, and internal and external review. Let's give you a moment to look at this. So the process can take, depending if it's a new book or an updated book, anywhere from 6 weeks to 3 or more months. It also depends on the workload of the copy editor and the graphic designers as well, and the medical reviewers. We do ask a lot of our medical reviewers. They review the clinical practice guidelines, as well as many of our other products, including the patient guidelines. There are currently 62 patient guidelines and over 60 translations in 21 languages, including Croatian, Czech, Hindi, Japanese, Korean, Ukrainian, and Somali. In 2020, there were over 2.2 million patient guideline downloads. Each book contains 3 opportunities for feedback. And we do consider the feedback when we're updating the books. And here's a current list as of last week, which was April 2022, of available books. I think mesothelioma has updated since then. Books include common and rare cancers, including lung cancer screening, distress during cancer care, survivorship, and immune checkpoint inhibitors. The version identifies the clinical practice guideline that the book is based on. So here, if you see like kidney cancer, it is based on the 2022 clinical practice guidelines. So you'll always know what version of the clinical practice guideline the book is based on. Since the books are not, they're funding dependent and aren't updated as often as the clinical practice guidelines, this is important. So you might have a book that's based on 2022, but here we're in, based on 2020, but we might be in a version of 2022. So just some things to keep in mind, that there might be a little discrepancy. As mentioned, you can view and download free copies of the NCCN guidelines for patients from our website at nccn.org/patients. High quality printed copies of the book can be purchased through Amazon. NCCN guidelines for patients are also available free on our mobile app. So what makes the guidelines for patients an authoritative resource? It is evidence-based, it is unbiased, and it is timely. The clinical practice guideline version is noted on page 2 of every book. Each book goes through a rigorous internal and external review process. Medical reviewers are from different fields of medicine to ensure clinical accuracy across a range of procedures and treatments. We also have subject matter experts on staff. These include scientists, nurses, oncologists, pharmacists, and imaging and radiation experts. And of note, every book contains a chapter on shared decision-making with questions to ask your doctors, now just questions to ask. We are in the process of removing doctor and replacing it with care team or provider. Patient guidelines are also a health literate resource. We have an in-house graphic designer who provides professional design and layout using a standardized format and who uses and applies ADA, American with Disabilities Act design principles. Our books are available in a variety of formats and can be read using a screen reader. We continue to make improvements on the ability of screen readers to read our books. Books are written in plain language using health literacy and numeracy principles. Information follows a clear, logic, and easy to read format. Again, it's a standardized format, which we'll discuss in a little bit. Medical terms and acronyms are defined. There is a glossary, and we call it words to know. And we also have an index. Graphics and images are used to increase comprehension and recall. And shared decision-making and patient engagement is encouraged and reinforced throughout. So let's talk a little bit about the books. Patient guidelines answer three main questions. What is it? How is it diagnosed? And how is it treated? All the books address this question, and they're all addressed in the same order. So what is it? Each book begins with a what is it chapter. It describes the basics about the disease, about the organ or tissue where cancer is found, how cancer spreads, etc. We always start with a brief overview of the disease, and we never assume anything. So we never assume that everyone knows where their breast is, or their stomach, or their uterus, for example. We do have reviewers that suggest we remove what they consider basic information. However, this information, it stays. It's important. It's definitely a need to know. So how is it diagnosed? Testing or how a disease is diagnosed always follows the first chapter. It includes tests and what to expect. So we're always trying to set the expectation, trying to define what the tests are, what tests you might have. Not everyone is going to have all of the tests, but since testing and diagnosis is part of the clinical practice guidelines or the CPGs, we cover it. We make sure that everyone is kind of aware what blood test you might have. So in this, in diagnosing or testing, you might find information on genetic and biomarker testing or staging. It really just depends on the disease, right? Not every cancer is the same. Treatment chapters include an overview of treatments, information about multidisciplinary teams, as well as specific treatment recommendations based on a cancer stage or disease subtypes. Algorithms or treatment pathways in the clinical practice guideline look like this. So this is an algorithm from just one page of the mycosis fungoides Sézary syndrome clinical practice guideline. So here you have it. How do you translate this information into a patient-friendly book so that this same information looks like this in the patient guideline? So, and this is a really good question, and I can tell you it is a lot of work. It is definitely a lot of work. And this is just the result of one algorithm page. There are multiple algorithms in each clinical practice guideline that must be interpreted and accurately reflected in the patient guideline. So the patient guideline must accurately mirror the clinical practice guidelines. We don't leave information out. We make sure that those with cancer, caregivers, healthcare professionals know what the treatments are, what the evidence-based treatments are. Information is often repeated throughout the book and is reinforced with the use of sticky notes, bulleted lists, sidebars, review sections, and in questions to ask. So here we have, they're basically three separate screenshots. The screenshot on the left is a questions to ask that are at the back of every book about treatment. And so those questions, some of them are general and kind of are carried over from book to book, but they're also specific to the disease type. And so there will be specific questions about chemotherapy. So in this instance, this is from pediatric ALL, and ALL is mostly treated with chemotherapy. So that's what we're calling it in this instance. And we'll talk about, it really depends. You'll see that there's bullet lists. We'll talk about maybe how the chemotherapy is given. If it's given through the mouth, under the skin, under the muscle, right, through an infusion. And so we just make sure that this information is repeated. So you're going to hear it in the kind of overview of treatments, and then you're going to hear it again in the specific treatment chapters. And then we use, as I mentioned, some sticky notes or sidebars to kind of enhance or reinforce information. A call to action. So sidebars, sticky notes, and active language lead to enhanced comprehension. The goal is to empower readers to take ownership of their care, be informed about care options, self-advocate, and engage in shared decision-making. So again, these are books. So we try to use active language in our sticky notes, in our text, and in our sidebars. So going beyond health literacy and the written word, a picture is worth 1,000 words. So we're going to talk a little bit about images. SEER demographic data is used to identify possible images. SEER stands for surveillance, epidemiology, and end results. So we don't only look at the highest incidence. So in this case, it would be white, non-Hispanic. So we don't just look at the highest incidence and put the highest incidence on the cover or inside the books. It's just one piece of information we consider. So trends or new research, maybe we feel like the books aren't targeting a certain population, so we might choose to put a person representing that population on the cover to kind of reach that specific audience. Every effort is made to include a variety of races, ages, ethnicities, and images of people, whether we use patients or healthcare providers, and procedures that include people or anatomy. And here we just have an example of a variety of chapters. So the making treatment decision chapter is always the last chapter. And then you can see that there are other chapters on just the overview of different conditions or staging. The use of images and other visual elements. So every book relies on illustrations and images to convey and reinforce information and to highlight diversity, to make it relatable. So here's a selection of some images. In our recent books, images are also used to convey special populations. This chapter image on the left was chosen because those with Down syndrome and ALL, so acute lymphoblastic leukemia, have special treatment considerations. On the upper right, we have a trans person for non-muscle invasive bladder cancer treatment chapter. So these were conscious choices, one of the decisions made at each step of the way. When possible, we use images that are gender or color neutral, like this red image in the center, or the non-human gray, as we call it. We do have some options, but we are limited by what is available through Getty or through Wikimedia images. So every effort is made to represent a variety of races and ethnicities. Those assigned male at birth can develop breast cancer. Hence the image choice for the inflammatory breast cancer chapter in the invasive breast cancer book here on the left. And you can see a selection of other images from our books. We use diverse images of skin color. On the left, we have an image of lumbar puncture and a bone marrow biopsy. These are Therese Winslow images. We do purchase these images from her. These are mastectomy examples that are used in the breast cancer series. So words matter. As writers, we are very conscious of word choice. Gender inclusive and sex neutral language is used throughout when possible. Males, females is preferred over men, women. This is a reflection of our clinical practice guidelines. When a distinction must be made, we use sex assigned at birth. We try to avoid regional colloquialisms and other terms that might be perceived as slang that have multiple meanings or may be difficult to translate. So examples might be wax wane, present or present, right? Start a family, father children, bear children, etc. Sometimes we're not even aware we're doing it. And when I was writing about skin lymphomas, I used wax and wane because the lesions on the skin can come and go, so they can wax and wane. But that is not a commonly recognized term. So we all learn something new every day. And language and word choice are an evolving landscape, often with much disagreement. A solid understanding of different perspectives is needed. So it is helpful if you attend webinars and have opportunities to just hear different perspectives, different voices, meet different people, because it can be difficult to kind of relate or understand where someone else might be coming from, because we really can only view things from our own perspective, from our own vantage point. And so as a reader, writer, patient, caregiver, survivor, etc., think about what terms you prefer, right? Is it a bias? Well, I don't know. If you prefer it, then I guess it kind of is, but maybe someone in the same exact situation has a different word that they prefer. So think about what terms you prefer. What are your biases? Are you even aware of them? And how do you decide on which terms to use? So gender expansive is a term recently used in a webinar that I attended that replaced gender inclusive. So it's not a term that's in the dictionary yet. And so does this matter? How does gender neutral language, right? So gender neutral, having no stance, differ from gender inclusive versus, right, including everyone? So does your organization have a stance? Does your writing have to mirror your organization's stance, right? So these are all things you have to consider. What is your stance? How does this affect your writing? And is it a bias? And are you doing your readers a service or disservice by kind of not recognizing these biases? So if you're trying to give equal weight to treatments and decisions, how are those fighting words perceived? The use of path or journey, disease path, cancer journey, fighting, right, fight, beat, win against cancer. So those are all, they're not new considerations, and those are all things we think about when we write. And so one of the things that I consider is that it is an option to not have treatment. So I make sure that readers in the patient guidelines are aware that you can choose to just have, not just, right? So I just said it there and I didn't mean to, but you can opt for supportive care. And there are many reasons why someone might not want treatment. And it's really kind of not up to us to judge, just to make sure that people have the information about financial aspects, how to pay for medicine, how to make decisions. You know, you just keep in the books reiterating all the support that is available, but you also recognize that you have a choice. And so you really want to make sure that you don't present one option with really not presenting the other. And so some other like hot button issues recently, not everyone likes to be called a survivor. Some people like to refer to it as living with cancer. Some cancers you don't survive. So what word do you use in that instance? Right. So we don't often use the word patients. We don't use it in our writing. We refer to as those with cancer or treating XYZ cancer. We try to decide how we want to distance it or personalize it. Like medical reviewers kind of prefer you use the word tumor or cancer, but sometimes then you're hearing the word cancer too much. So there is so much you think about all the time when you're writing. Just like risk factors. So research shows that risk factors are very confusing, but yet the clinical practice guidelines use the word risk, your risk. And, you know, are you doing a disservice by using the word chance? So they're just things that we struggle with when we write. And here we have the best choice, or the term now sometimes is not best practices, but better practices. So the treatment options, is there a right choice? I don't know. You know, there's a better choice. There's the choice that works for you. It's the same thing about language. You're trying to decide what words to use and not put too much emphasis on your doctor. Like these things are going to be done to you. Your doctor might order tests. Your doctor might do this. So we are aware that the patient advocates call this paternalistic. They don't want the focus on the physician, right? You want to be the focus on patient-centric. Using your doctor versus care team versus healthcare provider. We don't use images of people in hospital gowns. There's all kinds of reasons for that. The research is interesting. I feel like anytime I have a question, I do the research. I look up the research. What is the evidence, and how can I use this to make the decision? There are benefits to standardized headings. We have kind of like standardized headings and text for certain tests and treatments, and that really does help provide consistency across the books. And then we also receive outside feedback and internal feedback that we use to process improve. So more about language. These are examples of what I call gender omitted language. So in these examples, there is no mention of men, women, or males, females. Those who can become pregnant will be given a pregnancy test. There's no reason to say women who can become pregnant or men who have testicles. You can talk about these tests without mentioning gender or sex. And when a distinction must be made, sex assigned at birth is used. Our policy in the clinical practice guidelines is that the NCCN recommendations have been developed to be inclusive of all individuals of all sexual and gender identities to the greatest extent possible. Right? When citing data and recommendations from other organizations, the terms men, male, women, and female will be used to be consistent with the cited sources. And so here we have an example from the clinical practice guideline on the left about the special considerations for breast cancer in males, sex assigned at birth. And this information is then relayed into the patient guidelines. Questions to ask also address issues of race, ethnicity, and gender. For example, how many patients like me of the same age, gender, and race have you treated? It's just another way to start the conversation with your doctor and hopefully prompt patients and caregivers to ask to start this conversation so that everyone feels like they're getting what they need. So evolving language, there was a discussion in a panel meeting that I attended surrounding how upsetting the word infertility is to those trying to become pregnant. Also how upsetting are the pregnancy tests for those, because you get them before you start treatment and you get them frequently. And so it's kind of this constant reminder, this re-traumatization of those who are struggling with fertility. So based on these conversations, it was decided to change infertility to impaired fertility. And this change in the CPG, right, this clinical practice guideline, is then reflected in the patient guideline. And so we use, we're aware of age-sensitive language. This is something that I did bring to the attention of the department. Instead of using older and younger, we use over and under. No one wants to be labeled as old. And so here's just an example of under 60 years of age, 60 years of age and over. That's kind of our standard of how to phrase it. And again, with kind of this over and under, we can talk now about like numeracy. So on the right-hand side, again, you have this under 60 years of age, and in the clinical practice guideline, they use the less than 60, the less than symbol. And so it could get very confusing when you're looking at pages and pages of less thans and greater thans and equal to just kind of remember which one is which. Percentage is often used, or percentage is used and defined. So in this case, on the left-hand side for acute myeloid leukemia, the diagnosis is based on the number of blasts. So they're a type of cell. And so we define it, right? And so in this case, the lowest common denominator wasn't used. So like a best practice would be, 20% parentheses, 20 with the percentage sign, or more myeloblasts must be present in the bone or marrow. This means that at least 2 out of 10 marrow cells are blasts. So I made this choice because 2 out of 10 mirrors 20% easier, than 1 out of 5, even though 1 out of 5 is considered the lowest common denominator. This was a choice. Whether right or wrong, we have to make decisions, and the books range from 50 to 100 pages. So you're making hundreds of decisions all the time, and you can spend hours just rewriting sentences. So at some point, you just have to kind of make the best choice you can at that moment and move on. And in the center example, we use the number 3 instead of the word 3. Medical terms and acronyms are defined in the text. The medical term is followed by the acronym in the text. So the word or acronym, not both, are used in the headings. So this can be a little confusing, but we do have a standard. So you choose one, and it really depends. So in the case of ultrasound, we use the word ultrasound. That's kind of the familiar term. We do, in the paragraph, say in ultrasound parentheses US, we do put the acronym in parentheses, but we tend not to use it in the text because it's confusing. Is it United States? Is it ultrasound? So again, you're making these judgment calls. Sometimes when the word is too long, we might use the acronym in the heading. It just kind of depends what we consider more common. Right. So DNA, TB, those things are considered common. So we would use those acronyms and then put the full word afterward, or somehow kind of rearrange it. You can see a few examples here. But the word with the acronym it's not only in the text, but it's in our glossary, which is called Words to Know, and it's in the index. So we do repeat it. And if we're using an acronym, we do redefine the acronym, not every page, but every maybe new subject area, we do repeat it, just kind of as a reminder, because no one is reading the books cover to cover. People are flipping through, they might be looking up a test, they might be reading a section on treatment. So it is important to redefine those words. And we do use the correct words. We don't use slang. I mean, we might say chemotherapy or chemo, but chemotherapy is the term used throughout the book. And that's just a conscious choice that we make. So on to design and layout. As I mentioned, there is a formal, we do have a template. There is a formal InDesign template. Graphic designers use a standardized layout and apply character and paragraph styles for headings, text, sidebars, etc., to ensure consistency among the books. This test results heading is linked to the chapter table of contents, and in this header we call breadcrumb to assist with wayfinding and information seeking. This is a good example of some health literacy best practices. It shows bullets, headings, chunking information, and the spread incorporates a sidebar with additional helpful information. So our H1 headings, 18-point font with a color-friendly Pantone with black. Our subheading is a bold black, and then we have a third heading that is a blue. Sometimes the third headings, we try not to use them. They kind of come and go based on writing and design and other considerations. Here is another two-page spread example. It shows some of our branded items. So our tables are called guides. And I think this can be tricky because the clinical practice guidelines are called NCCN guidelines. The books are called NCCN guidelines for patients. Sometimes the chapters are called treatment guidelines. I try not to do that only because I feel like it adds to the confusion. And then these tables we use are called guides. It's just part of our branding. So something to consider. We also have these sidebars and these sticky notes. Like the whole layout is kind of part of the branding. All the books have the same look. And here are some more design layout examples that feature an image of radiation therapy, key points. And so in the center, there's actually 3 separate layouts here. The center key points used to be called review, and a medical reviewer kind of didn't like the idea of having it being called review, so we changed it to key points. And as mentioned, we do solicit feedback, and we do incorporate that feedback. And on the right-hand side, we have another example of a sidebar. Making treatment decisions is always the final chapter in each book. It is used to promote shared decision-making, getting a second opinion, seeking help through support groups. Questions to ask are part of this chapter. So it's a standardized section. We call it a boilerplate, again, to ensure consistency across the books. Another an example of standardized content or boilerplate would be our clinical trials section. So we have 2 kind of official boilerplates. So this is the same in every book. NCCN believes that the best management of any patient with cancer is in a clinical trial. This is at the bottom of every page in the clinical practice guideline, this statement. Participation in clinical trials is especially encouraged. So that statement as well. So that we emphasize kind of the importance of what is a clinical trial and how you can find more information, and to dispel some myths. Improvements, on to the good stuff. So past improvements have included, as I mentioned, these 3 surveys, these 3 opportunities to provide feedback. In our previous books, there was kind of a survey on the front cover that you could click and open, and we were finding that people were clicking on the corner to kind of turn the page, because we had a flipping book we used before. We used these PDFs. And so we were getting kind of like these false responses. People really didn't want to respond. They wanted to read the book. So these are our 3 in the center. You can see our 3 standard requests for feedback, and they're kind of throughout the book. We try not to put the let us know what you think, thumbs up, thumbs down after, a recurrence or relapse or metastatic chapter. I mean, we are careful of the placement and what it might imply. The test results section. So on the left-hand side, this is kind of a standard. Well, it's a standard boilerplate for me. I use it in every book, and some of the other writers use parts of it or all of it. It's really up to them. And so I came up with this test results, kind of create a medical binder section based on listening to a Health Literacy Out Loud podcast. And since that podcast, and since writing and kind of implementing this test results, I've received always positive feedback. They really like that I put it kind of at the beginning of the how is it diagnosed, how is it tested chapter. So I always kind of start off with this, and we can talk about a little more about some of the feedback in a second, but that's exciting. And the same with like sidebars. You listen to recordings, and so you all don't have access to these panel recordings, but sometimes in meetings they'll talk about, like one I attended was about pain, and they were saying that patients should keep a pain diary, but yet if I hadn't attended that meeting, I wouldn't have known, because we don't currently have like a pain management patient guidelines. So you do learn things, and it's helpful. It's just helpful to kind of, yes, I can do that. So recent improvements on the left-hand side, we're finding our way with this. We had this kind of cream colored sidebar, and now we're trying out a gray. And in some of the books, it's clear. I kind of like the gray. I did look at some of the research about color and how your eye moves through a page, and how color kind of gives your eye a break. So recent improvements also just kind of, you can see on the right hand side about finding a clinical trial. We have, as I mentioned, it's kind of a standardized look, and you can see a previous version from maybe 2 years ago of how it's improved. And the same with sidebars. So I had this, the sticky note that said, get to know your care team and let them get to know you. And a recent medical reviewer, when we were working on this animation script, said, help them get to know you. And so that makes, just think about those two sticky notes and the difference between what I had and what he suggested, and what it says, like how it improves it. So feedback is really important. The same thing, you're trying to encourage people if you need help paying for like medicine, because we're talking about financial toxicity. There's just so much to consider, and there's only so much room in the books. You really have to pick and choose what you're trying to highlight, and what maybe the issue is for that specific disease. And then there's an example about breast cancer, just a slight change. So as I mentioned, with the clinical practice guidelines, they used men and women, right? Anyone can have breast cancer, including men, that there are some differences, but treatment is very, very similar. So we just went to using males and females because that's preferred now from our clinical practice guidelines, and that treatment is very similar for all genders. So there, like I say, we're constantly making improvements and thinking about how to make our writing better, how to use better words. So here's like this future challenge. I was mentioning the test results, and creating a medical binder. And so now the decision has to be made about what feedback to incorporate to be consistent about multiple books. So there are 3 breast cancer, there are 3 books in the breast cancer series, and I did write all 3. So on the left, you have pre-invasive or non-invasive, which is DCIS. In the middle, you have invasive breast cancer example, and on the right, you have metastatic. And so each medical reviewer, the one medical reviewer for each book had a slightly different suggestion, which I incorporated. But since the books are written independently, like they're not, DCIS is not the same cancer as invasive, which is not the same cancer as metastatic. So I can't just take what one medical reviewer said and put it in another book that's already been through medical review. Like I have to leave those edits as they are. But when I'm working on the next book, I can now combine what I think are the kind of the best suggestions into one example, and then move those forward as a unit. So the one example was like kind of keep a primary care provider, like make sure you want them, and organizing the medical binder. Like one of the physicians said, well, patients might organize them in a way that's makes sense to them, but not helpful to us. So you're kind of balancing that suggestion. Like, how do I, well, you just have to balance the suggestion. So it's, there are things that I will think about and see what comes out the next step. So challenges, this is a big challenge, this idea of precision medicine and treatment designed just for you. So cancer treatment is becoming so individualized that the kind of the struggle between need to know versus a nice to know starts to get blurred. And the example would be on the left-hand side of chemotherapy. So these are chemotherapies in the breast cancer invasive and metastatic books. So on the left-hand side is kind of what was originally in the book. And on the right-hand side, where you just see a bullet list of all of the chemotherapy agents or the drugs. So I put this bulleted list in, and the medical reviewer wanted it the way it was, which is on the left-hand side, talking about anthracyclines and anti-metabolites. And so we do have to a certain degree, comply with what is suggested. We do list the drugs. We want to make sure that everyone understands what are the standards of care, which ones are preferred, which you can see a little in the guide on the top right. What is, so preferred is based on these categories of evidence. It's all described in the clinical practice guidelines, other recommended or used in some cases. So they're all like categories 2A unless otherwise noted. So all of that is kind of explained. We don't go into that type of level in the books, but so we put the information in about the different types of chemotherapy agents or the different types of targeted therapies, and the readers can choose to bypass it if they feel like it's too much information, but it's there. And we do try to, again, use sticky notes to kind of just explain the difference between chemotherapy and systemic therapy and targeted therapy. Areas of improvement. So I mentioned our questions to ask your doctors. We are changing that to questions to ask. We're considering just questions to ask in general, and then maybe questions to ask your care team about their experience versus always focusing on the doctors. We're still kind of working on that change. We try to make the changes all at once to ensure consistency. We do still struggle with images, diverse images of skin color. We do purchase our images, not all of them, but even when you purchase them, it's hard to find diverse images of skin color, especially when you're talking about skin cancers and skin lymphomas. What else? So word choice and language can always be improved upon. You can see that some of our books are still using older and younger. Some are still referring to women. And you can, think about those things. And doctors and this is my example, I will freely admit it. Doctors write these stages as, well, do I really need to say that? These stages are written as, so trying to kind of ease up on the word using doctors too much. So resources and websites. Each book has a list of selected resources or websites for more information. Writers often use these resources as well. They are hyperlinked. You can see that we use resources in our sidebars, in our sticky notes as well. And here are a few lesser known resources that I highly recommend. I've included some of my favorites, like Skin of Color Society and rarediseases.org. There are a lot of great websites out there. I'm sure you have plenty as well. My survival story, Medline.plus, especially with the genetics and the biomarkers. We had genetic and biomarker information on our website, but it is nice to find information that is in plain language as well. Additionally, we have the National Institute of Health Resources, and the National Cancer Institute has an excellent dictionary. Medline Plus, as I mentioned, has a genetics section and genetics home reference, which is helpful, especially when you're dealing with blood cancers such as MDS or AML. And some health literacy related resources. Of course, I have not included all of them. I just included some of the ones that I use. I feel like, maybe subscribe and follow as many as you can. And then when you can start to pick and choose, kind of glean which ones speak to you. What else? Oh, I do suggest this medical libraries discussion list. You don't have to be a librarian to subscribe to that list, and consider some state health literacy organizations or coalitions. And so, for example, I am a member of the Pennsylvania Library Association. I am chair of a literacies team. And so there are, same thing, you can subscribe to different listservs and find information about health literate resources. So I can't believe the hour is up. I want to thank you for your time and ask what questions you have for me. And since this is a recording, you can feel free to reach out to me at fisher@nccn.org. My last name is spelled Fischer. And thank you so much. I hope I've given you something to think about, and I'd love to hear from you. Have a great day.